Well, good morning. Thank you for letting me be here. My name's Joe Bozzay. I'm from Walter Reed, and I'll be discussing how we implemented our emergency general surgery process improvement program at our military center. I have nothing to disclose. So process improvement is a method for evaluating and reevaluating aspects of clinical care and practices in order to bring about improved patient care and outcomes. This is done through a process of recognition, assessment, and correction of aspects of clinical practice, and it is facilitated by a good program which includes peer review, a data registry that allows you to capture certain events, clinical practice guidelines, and then appropriate personnel. A good program impacts your clinical practice, especially aspects of patient care such as outcomes, hospital reimbursement, perceived hospital quality, and then even litigation. Nationally, NSQIP and TQIP do this for general surgery and trauma surgery, but no national emergency general surgery quality improvement program exists. Recently, there was a call for the establishment of an EGS quality improvement program, noting that given the disparity in adjusted outcomes nationwide, you could save thousands of lives if this is implemented. So in 2013, we decided to merge the care of our emergency general surgery patients and our trauma patients under one team. We did this for a couple reasons. First of all, emergency general surgery and trauma patients share hospital resources and are similar in aspects of patient care. But also this impacted us personally because of the combat operation drawdown overseas. Our trauma admissions dropped dramatically, which is good for our combatants, but not so much for maintaining medical readiness and keeping up with the volume of patient care. We also noted that because of this, our existing trauma process improvement program didn't have the volume that we wanted so that we could continue to examine our patient outcomes and care. So our goal was to take what we had done with our existing trauma process improvement program and develop a similar but tailored program for our emergency general surgery program, or our emergency general surgery patients. Again, this hasn't been done, so we based this off our trauma surgery principles, but we tailored it for our EGS patients. So we began this in January 2016, about 3 years after merging the care of those patients into one team. So as you can see here, we designed it to mirror our trauma program with tailoring for EGS patients, and I'll get to some of that in a minute. So criteria for registry inclusion for our emergency general surgery patients included conditions such as an incarcerated hernia, diverticulitis, appendicitis, or gastrointestinal bleeding. Events or complications or filters, it all means the same thing, included our less ideal outcomes such as surgical site infection, readmission within 30 days, or unplanned return to the operating room, among others. So we actively reviewed the inpatient record for admitted patients for the first 30 days, looking specifically at aspects of clinical care and patient outcomes. These findings were collated, addressed, and analyzed. And from this, we developed areas that where we thought we could improve the care that we provide to our patients. We called these process improvement initiatives. I'd like to point out here a few notable events for our registries. If we had focused solely on our trauma process improvement program and for improving the care to our patients, we would have missed events that emergency general surgery patients gave us. Especially as you note the readmissions and infections as well as unplanned therapies. So if we'd relied solely on our trauma program, we would have missed these events that emergency general surgery patients provide. Just a quick subset analysis here. We looked at various initiatives here, and we recognized, for instance, that post-op wound infection and wound complications accounted for almost 50% of our readmissions for our EGS patients. We also noticed that unplanned therapies, about 30% of those involved our endoscopic colleagues or our interventional radiology. So we have this data. What do we do with it? We want to improve the care that we provide. The first thing we did was take something that we had done for our trauma program and implement it for our emergency general surgery patients. So we developed a standardized reference for our house staff. Not only does it discuss the clinical practice guidelines and the roles and responsibilities of each team member, but it also discusses the aspects of process improvement and why it's important, especially for the residents. A key aspect of our interventions was the development of a multidisciplinary committee. So we recognized that many of our events involved multiple medical specialties. So from this, we saw an opportunity to bring these specialties to the table in the form of a committee so that we could all work together to improve the care that we provide to our mutual patients. So now a team composed of specialists such as gastroenterology, interventional radiology, and emergency medicine, we all now meet monthly to discuss aspects of patient care, to review cases of interest, and to try to improve the care that we provide to our mutual patients. It's based on our trauma committee, but it's tailored for our emergency general surgery patients. We've noticed that in addition to impacting the care that we provide, it's actually generated hospital-wide interest and process improvement, and we're very enthusiastic about this. And side projects have developed from other teams. A notable difference here, for instance, orthopedics and neurosurgery are involved with the care of trauma patients, not so much with emergency general surgery patients. However, gastroenterology is a huge component of emergency general surgery, as well as emergency medicine and internal medicine. So again, this is why the peer review is different, but we did base it off our trauma principle. As a result of our multidisciplinary committee, we also developed evidence-based consensus protocols for the treatment of diseases mutually treated by these specialists, such as gastrointestinal bleeding, biliary disease, and pancreatitis. Not only does this unify our approach to these diseases, but it also facilitates better communication amongst the teams. Just real quick here, for some other subset analysis, we noticed that sepsis accounted for almost 20% of our unplanned ICU admissions. We looked at these patients and realized that not every patient was receiving the same standard of care, i.e. they weren't getting the antibiotics within an appropriate time. Not everybody was getting a fluid bolus. The same workup wasn't being done. So actually, as a result of this committee, we are in the process of finalizing an institutional sepsis protocol. So this has brought about a change to the entire hospital. And we're very excited about this. Furthermore, we noticed that outpatient wound care interventions accounted for about 15% of our readmissions, so we started changing the wound supplies that we keep on hand. And we found that we've actually been able to facilitate continued outpatient care of certain wounds that would have otherwise resulted in a readmission. This came again as a result of our registry. So in conclusion, by incorporating our emergency general surgery patients into our process improvement program, we uncovered over 200 additional events in an 18-month period. Not only did this increase our process improvement event volume, but it allowed us to more easily identify trends in areas where we can improve the care that we provide to our patients, as well as we hope, our outcomes. So we hope this will improve our care and our outcomes, and I think this provides a good basis for looking into doing this for emergency general surgery patients. Thank you.